This is Emily Peters recording for Care of the Growing Family, Unit 5, Health Problems of the Newborn. Alright, so we've kind of touched base on a few of these things over when I was going over assessment and changes the newborn goes through. But when that baby's going through the vaginal canal, there's some soft tissue injuries that can occur. So we're looking at forms of head trauma. Those head traumas are included in cephalohematoma and caput seducium. We can also have subglial hemorrhages. We're going to focus more on the cephalohematoma and the caputs. So when you're looking at the little guy's head here, you can kind of see that it has an accumulation of fluid or something underneath the skull off to the side a little bit. This is probably a cephalohematoma since it is off to the one side. It is a accumulation of blood between the cranial bone and the periosteal membrane due to blood vessels that are ruptured. So here's another view of a cephalohematoma. They can be unilateral or bilateral, so they could actually have two of them. These typically show up like 1 to 2 to 3 days after birth. However, a caput can also be formed over top of the cephalohematoma, so you may not see it. Cephalahematomas do not cross the suture line, so they are off to one side of the skull. They disappear pretty slowly. It can take several weeks. Because it's an accumulation of blood vessel or broken down blood, these kids are going to be at higher risk for jaundice due to those red blood cells that are destroyed related to the hematoma. And they're going to have lots of bruising. Here is the caput. So a caput is more of a localized soft spot on the scalp. It is present at birth. It is the result of a long labor or even a vacuum extraction. A caput will override the suture lines. We see this pretty quickly after the baby is born, and it is gone within 12 hours to 2 days after birth. And that is why we sometimes don't notice the cephalohematoma until after a couple days if they have a caput over top. Remember, a caput crosses the suture line, so it's going to cover more area of the skull. So one way to think about it is a cap over the kid's head. This is just a quick visual that kind of gives you a breakdown of the difference between a cephalohematoma and caput. I can't remember if I mentioned it, but the caput is a fluid-filled presence or underneath the skin. Here is a mnemonic for you guys for caputs. All right, so some other birth injuries that may occur, and I've mentioned a few of these often on when I've been talking about issues. You have fractures to the clavicle. You can have facial paralysis. You can have brachial palsies, phrenic nerve paralysis, and cranial deformities. So, fractures of the clavicle. Some babies, when they have a fracture of the clavicle, you will notice that they are guarding of their extremity, or they may not move that extremity as much. However, I have seen several babies that you do see them moving around their extremity, and it's more We end up realizing that it's fractured due to the nurse palpitating the crepitus in those broken clavicles. So that's why it's really important we're doing that good, thorough head-to-toe assessment and feeling everything. If the child does have a clavicle fracture, what we're probably going to do with it is just manipulate that arm or that side of the extremity less frequently. So we slide the clothes up and over that side and then manipulate the opposite extremity. We won't use that arm axillary area for temperatures. It is not uncommon that we'll just kind of splint it by, without using splints, but more of supporting it by swaddling the baby. Let's see. Facial paralysis hopefully will be temporary, but it can occur as well due to I'm misthinking, due to the pressures of the delivery and the baby coming out. Hopefully it is going to be a temporary thing, and as that baby is recovering from the delivery, we will start seeing movement again. There is some PT and OT that can occur. Some things that sometimes cause the paralysis is the use of forceps. Brachial palsies, or also known as Herb Duchenne palsies, are a paralysis of the arm, and that's also related to trauma at birth. The Herb Duchenne is more on the upper arm. Hopefully it will resolve completely on its own. If it does not, they will do some PT, OT, range of motion. Sometimes they do also splint. Sometimes with these brachial palsies, that you may even see that they also have a broken clavicle. Phrenic nerve paralysis, once again, forces a delivery. Hopefully it's a temporary paralysis, and we can then work on PTOT, and hopefully the baby will start to gain the movement back. Cranial deformities, the most common things we end up seeing is the overriding sutures, sutures that are split more than normal. Once in a while, due to the baby laying on one side of the head too much, you'll start to see flattening out of that side. And then we just work on rotating of the way the baby's facing for cares. Here is a baby that has Erb's palsy or brachial palsy, essentially. You can kind of see the poor rotation in the arm. All right, hip dysplasia. So, a lot of babies can end up developing hip dysplasia. All right, so sorry, I had to take a short little regather my notes there. So hip dysplasia. A lot of babies, and not a lot of babies, actually it only affects about 1 to 2 kids out of every 1,000. Congenital hip dysplasia or developmental dysplasia of the hip is basically when your child has a hip instability. It is more common in our girls and Caucasians than males and other races. I want to say it's more common also in the left hip. Now, what leads to it for the etiology? We're not 100% always clear on what led to it. It could be intrauterine position, so is the kid breech, or is the one leg kind of pressed up against the uterine wall too much? Is it multiple births and 2, 3, 4 little babies trying to fit in such a small space? Oligohydramnios. Family history increases the likelihood of another kid having a hip dysplasia. We've also noticed that sometimes when babies are born, they don't have a hip dysplasia, but due to the swaddling tightly of these babies with their hips in an abducted and or an extension position, it pops that hip out a little bit more, so it doesn't allow for as much movement. There's 2 different forms. You don't really need to know as much of it, but just to recognize that there's a couple different groups of reasons why it occurs. We have perluxion, which is written up here. You just have a little hypoplasia. This is more of a dysplasia, where that there's a slight subluxation, but the femoral head remains in the acetabulum. We have a full subluxation, where you have an incomplete dislocation of the hip. The femoral head is still in contact with the acetabulum, but it can be displaced. Then you have the dislocation, where that femoral head loses contact with the acetabulum. The subluxation, I believe, is the most common form. So this is just kind of looking at the difference of it. Dysplasia, you can see there's just a slight change, whereas the subluxation, you have a little bit more of a dislocation. So how do we diagnose these kids? So before we can even get into early intervention, we need to figure out how to diagnose them. So how do we notice this? Well, part of our nursing assessment is looking at how those hips are moving. So we do the Ortolani's and Barlow's maneuver. With Ortolani's, when we're moving and checking the hips, you're noticing that the hip is then reduced by when the legs are abducted. With Barlow's, you notice that the hips dislocate when there's adduction. Also, when we're looking at the babies, we notice that we have shortening of a femur, or we're noticing like asymmetrical gluteal folds and asymmetrically of the with the thighs and the length. So we want to do some early intervention. The Pavlik harness is very common. What we do with this is it immobilizes the child's hips in a flexed abducted position with this harness. The harness is great because you can still get a lot of movement with the baby and interaction and holding of the child, because there's lots of, it's not as restrictive, I guess is a good way for it. They're going to wear it continuously for several months, and then we just need to make sure that the only person that adjusts the harness lengths for growth is the doctor. The parents, the nurses, they don't do any of that. Some parents are allowed to take the harness off for bath times, but not all the time are doctors allowing that. Another option is, besides doing a pelvic harness, is doing a hip spica cast. So the hip spica cast is basically a cast that goes from the hips and down through the legs, and they hold that baby in that abducted position. The issue with this cast is movement is a lot more limited, and we have to do extra skin care because of there is even casting around the groin area, so there's only just a little bit of an opening, and having to really be particular with diaper changes. The spica cast we sometimes do when those kids are older, before we go, if they're diagnosed older, or if like the pelvic harness does not do its job. When we're doing any kind of splinting or harnesses or casts, we need to make sure we are doing good site care, circulation checks, and things like that. Trying to make sure I don't forget anything that you guys need to know that's important. Sometimes they'll do just true traction, like you would use in the hospital with the weights for older kids. They'll do that maybe shortly before doing a surgery, and then they can go in and surgically reduce the issue and put everything back, like the hips back the way they need to do. And then, of course, even with traction and then going to surgery, they're going to end up with a cast afterwards. They will change the cast multiple times to help with growth. So, like I was saying earlier, what are some things that we notice? So that shortened limbed, restricted abduction, unequal gluteal folds, positive ortolani and positive Barlow. So the positive ortolani would mean that I saw or felt the hips reducing when I'm abducting. A positive Barlow is when I feel the hips dislocating with the adduction. So this is an example of both of them. So you can kind of see in A that you can see the asymmetrical folds. In B, they are doing Barlows. And D is ortolanis. E is also seeing that you have a change in their length of the legs. Excuse me. These are some other signs that you might see in an older infant or a child that ends up developing dysplasia of the hip. I want you guys to more focus on the infant, but just be aware of that we may see some different things as they're older. Here's just another picture of the asymmetrical gluteal folds. And this is them doing Barlows and then ortolanis. Barlows is A, ortolanis is B. Here's an ortolanis. I believe they're getting ready to start Barlows here. And this is ortolanis. Here's a visual for you guys, or a mnemonic, so you can recognize what to look for hip dysplasia. I apologize, this is a repeated slide. I just discussed all of that earlier. So maintaining reduction, that's really important with the pelvic harness. That's when we're teaching the parents on making sure that they're not moving the harness positioning at all or readjusting it, and they know how to take it on and off if they're allowed to for baths. And the importance of maintaining that reduction is to keep that hip where it needs to be and allow the joint to strengthen and the muscles and ligaments to work. Skin care, we will clean around where the site of the harness is at. Usually you have like a harness up and around the hips and then a couple things on the legs. And you're just going to do good site care around that. Make sure that child has some range of motion and you can feel all pulses. Here's an example of the pelvic harness. Cleft lip and cleft palate. Cleft lip and cleft palate are somewhat common. It's facial malformations involving the lip or the palate, or a combination of the two. The lip is a failure of the maxillary and medial nasal processes to fuse. The palate is a midline fissure of the palate resulting from failure to close the two sides of their palate. So some problems with both of them are we end up having some feeding issues. They can have long-term issues with dentation. They can have language developmental issues, hearing issues. What causes it? There is an inheritance with it, an inheritance issue. So we can see a family history. There's some genetics as well, and exposure to toxic substances while mom is pregnant. Repair of the cleft lip, around 2 to 3 months, 6 to 12 weeks. The cleft palate takes longer to repair. Typically that kid is around a year or 12 to 18 months. Some of that is to allow for a lot of growth to occur developmentally. It is not uncommon with the palate for them to have a secondary surgery later on as well. Club foot. I think I have some slides mixed up. I apologize. Club foot. You have different kinds of club foot, how they bend, and dorsiflexion and things like that. I'll get more into club foot when we get to the other slides. You don't really need to know all the different classifications, but I'm just letting you see that there are different classifications, and depending on the severity of it will depend on what we can do for correction. Here's an example of club foot. Diagnostic and evaluation. What are we going to do with it? So some of the things we do is we're just noticing how it's bent and things like that. When we're going to fix it, we like to use, and I'm forgetting the name of it, Ponsetti's method. Dr. Ponsetti is actually, he is from the University of Iowa, so we're pretty lucky to have the top of the education here locally. Dr. Ponsetti is designed this method to a non-surgically method to help with the club foot. And nursing considerations, same with other things, and I'll get into that more when we have our next congenital club foot slide, which should be here after I get back onto the pelvic harness, or no, the cleft lip stuff. Okay, so these are the slides that was supposed to pop up. So this is an example of the cleft lip. So that little guy has the lip, and then you can barely see he's had his surgical procedure. His procedure was probably done pretty soon after he was, like I said, a couple months old. This little baby has a bilateral cleft lip. It would not be surprising because it's bilateral that she may also have a cleft palate as well. Her lip repair was done early on, and if there was a palate, it probably hasn't been done yet. Alright, this is where it was supposed to be going next. So with care of with cleft lip and cleft palate, big things is nutrition. These babies cannot get a good suction when they are eating, and therefore we end up having a lot of nutritional issues. They actually say breastfeeding is easier for them because they can get a good seal around the breast, but sometimes it's not enough for nutrition for them. So when we do give bottles, we have to use special bottles with special nipples that make it easier for the kid to get the nutrition due to the inability to have that good suction. We are going to limit the length of their feeding sessions as well so that we don't fatigue them and burn more calories. We like to have them sit up in more of an upright position as well. Post-op with the surgeries of the cleft lip and palate, mostly the lip, is you're going to have to really protect that surgical site around the lip. So to do that, it's not uncommon for us to do elbow restraints on the babies to keep their arms from bending and their hands from getting to their mouths. We also can do suture line care along the lip line for the several days afterwards, and we'll just do like a petroleum jelly. So take like a little Q-tip and put some petroleum jelly on the site. As they are healing from both the cleft lip and cleft palate, we have to be very careful with what they put in their mouth. So no straws, no spoons, no pacifiers. We typically soft foods if they're old enough. No tongue depressors, things like that. So especially with the palate, because we don't want to rupture the opening of their palates. It is not uncommon for these guys to have a lot of orthodontic issues. In fact, sometimes their teeth will not grow back in normally, and therefore we end up having dentation issues. The teeth will grow in different spots, and actually I've heard of kids that their teeth is trying to grow in through the fixed palate, so they have to pull teeth as well. They also end up needing maybe orthodontic care. So everybody that's going to be involved is going to be pediatric teams, plastic surgery, orthodontics, otolaryngology, speech, auditory, because it's not uncommon for them also to be prone for ear infections and hearing loss, social workers, nursing, speech therapist. Everybody needs to get involved. They sometimes have to go through speech development classes. Lots of long-term care with these guys. I know several people that have had cleft lip and or palates that are doing great because they've had enough therapies. One issue that we can have with these kids is attachment issues with the mom and the baby. So we want to make sure that those parents and babies are bonding appropriately. Okay, now back on to clubfoot. So, like I said, it's not very common with clubfoot. 1 to 1,000 kids. 1 in every 1,000 kids. Boys more often. We don't know the cause of it. The positioning intrauterine, genetic. If a parent has it, I believe it's also more common for them to have it as well. So I was mentioning Ponseti's method, and Ponseti's method is this serial casting, where we're taking lots and lots of casts, and as we're casting, we're manipulating how that foot is turned. And as that baby grows, we take the cast off and put a new one on, and kind of straighten out that toe, or that foot. If it's a bony abnormality, the serial casting probably won't do the job, so they will have to go through and do a surgical repair. People come from all over the world to do the Ponseti's method here in the corridor at the university. So we're pretty lucky that we have the doctor. Well, he's no longer alive. He was practicing until his late 90s and died in the last 5 years. But the serial casting is amazing, and as a kid grows, they just take it off and put a new one on and adjust how that foot is turned. So here's a picture of a kid with a club foot and then the serial casting that is going on. These kids learn to crawl with the cast and they learn to get very mobile. Oh, structural defects. We have hypospadies, epispadies, and cryptochidism. Hypospadies, 1 in every 250 males. It is an urethral opening of the penis in the ventral part of the penis, so located on the lowest surface of the body. These kids can have urination issues, erection problems, and infertility issues. With epispadies, this is less common, 1 in 10,000 or 50,000. It's a urethral opening on the dorsal or on the back side, so the upper part of the penis. Cryptochidism, undistended testes. This we will have to treat surgically. Because that is, if those testes do not distend, the heat and the poor blood supply to the testicles could make the child sterile. All of these are going to be surgical intervention. With epispadies and hypospadies, they will sometimes wait to do the removal of the foreskin until they decide to fix the urethral opening, because they can use that skin as for some of the repairs. There's some body image concerns if we do not do the repairs, but also with the repairs, parents are wondering if there's going to be deformities or if it's going to be noticed. There's also that fear that when we're going through and doing the surgeries, and since we're working with the sex hormone or sexual parts of these babies, the parents are worrying about castration and mutilation, and those things are very rare. We like to fix this earlier rather than later, so we like to get these issues fixed before that child is 3. So hopefully in that 1st to 2nd year of life, before they learn to potty train. Big issues is post-op care. We want to make sure that we're doing good site assessments and cleaning, especially since this is down in the groin region, that we do have a lot of bacteria growing. There is some talk about not doing bathtubs, tub baths with these kids. I'm not sure what the protocol on that is anymore. Some kids will come back with a catheterization for a while, just to make sure that their bladder is flowing and they can that urethra can heal appropriately. So just remember all your calf cares. All right. So we have jaundice or hyperbilirubinemia. I've kind of explained this some, but what's really going on with hyperbilirubinemia is we have that high level of unconjugated bilirubin. So you have those shorter life of the red blood cells being 80 days because they're fetal hemoglobin versus the adult hemoglobin that has 120 days. And then the fact that that baby has that immature liver, so that it's not filtering things as correctly. We also have increase in red blood cells and polycythemia, which is a high hemoglobin. So you have this imbalance between the production and the elimination of bilirubin, essentially. We have jaundice versus icterus. With icterus is when I was talking about canicterus, so when it starts becoming more of an issue and causing more intense issues. You have hemolytic or pathologic versus physiologic jaundice. To tell the difference, you look at what's going on with the baby and when you see it. So physiologic jaundice is when you have the infant is doing really well, and then it appears after the first 24 hours, and then 7 days later it's gone. The peak level of the jaundice or the bilirubin is going to occur around day of life 3 to 5. Unconjugated bilirubin doesn't typically exceed a huge number. So we have like 5 milligrams per deciliter, things like that. The rate is more gradual with the physiologic jaundice. Then we have non-physiologic or the pathologic jaundice. This one occurs more rapidly. So we're going to see it when that child is less than 24 hours old. Their bilirubin increases more than that 5 milligrams per deciliter per day. It occurs with anemias. This is one that we see with ABO incompatibilities and Rh negative issues. This is the one that ends up going more into icterus or canicterus, which that's when that bilirubin precipitates into our neuronal cells, and that can lead to like cerebral palsy, mental retardation, and epilepsy because of that huge destruction of red blood cells going on. We have the jaundice associated with breastfeeding, and this is more of a physiologic thing. We see that bilirubin levels rise after 3 to 5 days, and that's because there's not a lot of breast milk going on, and what's going on in the breast milk that they're getting, it interferes with that conjugation of the bilirubin. So we're just going to closely monitor the kids' bili levels. Pretty much with every type of bilirubin issue, we are going to treat with phototherapy. We have jaundice related to breastfeeding due to just the poor intake of fluid, that baby's sleepy, and they're not stooling as frequently, or they're not sucking well. This we see more common in smaller babies, and babies that maybe have had a rougher start, per se. So diagnostic evaluation, so we're going to look at their belly levels. All babies get their belly levels checked. We do quick chest checks over their forehead, like a tympanic way to read a bilirubin. And then if the number is a little high, we will go ahead and do a venous stick. Typically we'll just do a heel stick and get more of a true blood result. Management, we're going to want to make sure this baby's feeding and staying hydrated, and then we're going to start phototherapy. Now, if it starts going into more of a pathologic issue, sometimes we will have to do therapeutic management by doing partial exchange, where a partial exchange means that I'm trying to dilute out the blood. So we may take 10 cc's of the baby's blood and then put 10 cc's of like a normal saline back in. Now, granted, I just made some numbers up, but it's usually an even number of amount of blood that's coming out, the same amount of saline is going to go back in. Hyperbilirubinemia, prognosis is actually really good unless you start getting extremely high levels, which typically happens with those pathologic things if we don't stay on top of it. So this little guy is in his Billy Lights. You can see that he has those cute little glasses on, protecting his eyes, and his diapers are on, protecting his groin. Otherwise, he is naked. He has probably a billy bed, and then he has lights over top of him. We want to get as much of his body covered by the Billy Lights. The lights, they're like a UV light, but they don't produce a lot of heat. They won't tan the baby, but they will help with the breaking down of the bilirubin and helping with the switching from unconjugated to conjugated bilirubin, so these babies can then excrete it. Here's another example of a kid getting his Billy Lights done. So RH incompatibility and ABO incompatibility. Basically what I want you guys to know about that is that we can have some blood issues that are leading to the pathologic forms of it. And this is when I'm talking about the exchange transfusion. We have a partial exchange versus a full exchange. Partial exchange is so many cc's of blood removed from the baby, so many cc's of fluid, like saline, put back in the baby. A full exchange is I'm taking so many cc's of the baby's blood out, and then I'm putting the same amount of cc's of donor blood in. Once again, we're kind of diluting out the amount of bilirubin floating around. Some things that we can do to prevent this pathologic bilirubin issue is to give RhoGAM to those moms that are Rh negative when they're pregnant. This is just kind of giving you a breakdown of what Rh incompatibility is doing. It is Rh negative mom that then their body produces antibodies that fight off antigens that are going on, and then eventually what could happen is that fetus can be attacked. So maybe not that first pregnancy, but the pregnancies after. So this is just kind of showing what happens in that secondary pregnancy, and that second baby may die. And that is it. I want you guys to focus more on the difference between pathologic and physiologic, and some treatments. Now, when a kid is under Billy Lights, we'd only take them out of their Billy Lights for feedings only, and we want them to be calmed and soothed when they're under the lights. Now, we do sometimes take the lights off during assessment for a few minutes, and when we're changing the diapers, but other than that, they should be under those Billy Lights 24/7.